I just want to introduce our first speaker, Dr. G.R. Thompson. He is a professor of medicine at the University of California, Davis School of Medicine. He has a joint appointment in medical microbiology and immunology and in internal medicine. And we're really delighted and honored to have G.R. Thompson as our first speaker. He's a leading medical mycology clinician with additional broad research interests in fungal diagnostics, trials, and novel antifungal agents. He's served on the IDSA program committee. He's a member of the Coccidioidomycosis Study Group Planning Committee, chair of the Mycosis Study Group Education Committee, and he's also served on the FDA Antifungal and Coccidioidomycosis Advisory Committee and has been a congressional consultant for the Valley Fever Task Force. So no better person to talk to us about coccidioidomycosis and new antifungals. So over to you, GR.
Well, great. Thank you so much, Tom, for that kind introduction and for the opportunity to talk today. I know this is an infection that a lot of people don't have experience with, so we're going to start just with a little bit of background about the infection and approach it more broadly, and then talk through specifically some of the more novel treatment options that we're having to use for these patients. Here's my disclosures for the talk today. And then I think it's really important to emphasize, I know a lot of people have seen this. This is the fungal priority pathogens that were put forward by the World Health Organization just about a year ago. So there's obviously the critical group, which we see a lot of with Cryptococcus neoformans, Candida auris that's emerged globally, Aspergillus fumigatus, which needs no introduction, and then just the burden caused by Candida albicans. But as you look towards the right there, you can see in the medium group, Coccidioides is listed here, even though it's an endemic pathogen with a fairly narrow range. And the reasons for that are multiple. Climate change has played a big role in the spread of this infection, as you'll see in the next slide. We're seeing this in new areas, and then our patients do travel a lot. And it's thought that 10 to 20% of all Coccidioides infections are actually diagnosed well outside the traditional endemic region. And I'm aware of at least one case that's active right now in London. And certainly we are called about those every couple of years. We take care of a lot of these patients internationally who've gone back home and been diagnosed or transferred their care. So this infection continues to be of both regional and global importance, and that was outlined here by the World Health Organization, and we're certainly grateful for that. And then just a few more things about the background of this. So Coccidioides, the good part of the infection is most people never know they had it. So they've breathed in the spores, their immune system responds appropriately, and they have subsequent immunity. The bad part is the group, which is about a third to two-thirds that have symptoms, they can have really a prolonged infection before they really improve. And then a minority of those can disseminate or cause a chronic form of infection. It's so frequent within Central California and Central Arizona that it causes about a fourth of all community-acquired pneumonia. And you can see here statistically, Coccidioides has increased in the burden of infections really over the last 2 decades. And the reasons for that are multiple. And then Morgan Goris had published this paper that's outlined on the right in this figure that shows the United States. And this is under different climate warming scenarios. And you can see what that looks like in 2007. And this is a county level analysis. So they used the burden of infection that had been reported. They used climate factors, including the soil characteristics, pH, precipitation, et cetera, and then looked through these moderate climate warming scenarios, and you can see there the spread of disease that's anticipated through 2095. And then there are a high climate warming scenario. Obviously, this is going to cross the Canadian border. It's clearly in Mexico already as well. And when this paper came out, I was actually quite skeptical of this report and thought maybe this was a little bit of a doom and gloom scenario. But we've been called on patients in Kansas, which is outlined here in the middle of the United States. There's an outbreak in Nebraska just last year. And then we're aware of cases in Idaho and some of these other northern states. So we do think Coccidioides is probably already there, which is a little bit troublesome, obviously, that we're seeing this continued spread of this endemic infection across the United States. And so this is one of the reasons why. So Coccidioides has this very clear association with temperature and precipitation patterns. And it's really a 2-year cycle that determines the burden of coccidioides infections after this. So with heavy rainfall and precipitation, you can think of it as the mold form will grow in quantity in the soil during that time frame. Coccidioides is highly linked to several of the mammal populations, mostly rodents and mice in the environment. And it's thought that with heavy precipitation, certainly the soil prefers that for growth conditions, but it's likely that the rodent population also increases with heavy precipitation as their food sources increase. Following that with drought, the mold form in the environment or mycelial form will convert to spores. And so that period of drought is really needed for it to recapitulate its life cycle. Those spores during drought become much more easily airborne. And that's through either just activities, windstorms, which certainly coincide with drought, or construction. And there's been a lot of construction during some of these areas within Central California. And we think that's playing a big role in why we're seeing more and more infections. And then lastly, people like to ask us if I take a vacation to California or to Arizona, what's my risk? And so how frequent is exposure? And you can see here of Phoenix, Arizona, which is the 4th largest city in the United States. The city is basically blanketed by these dust storms periodically. That exposes, we've always thought, a lot of people. We think it's good that most people in these regions already have pre-existing immunity, but there's now thought to be about 500,000 cases a year within the United States. Symptomatic infection only occurs 0.5 per 100 person years. And then there's certain groups that have very high seroconversion rates, and that's particularly military recruits who are sleeping in the dirt outside for long periods of time. But for the lay public, your risk is about 8% per year. We think that this has really been compounded with sociologic factors. There's been a housing crisis in the United States where people have had to move from areas with very high housing that don't have cocci, sort of inland to California for areas that do have cocci, but have much cheaper homes. And so they're non-immune and moving in at an older age when they're going to have more severe infection. Coinciding with drought, we've also seen a lot of wildfires within the United States. And so we had noticed this association of fungal diseases and wildfires a few years ago and published that there is a living component of smoke. And so we think that really plays a key role in pathogen spread. We've looked at these from controlled burns and done drone sampling over these smoke plumes. And you can see this map on the bottom, how far these smoke plumes move. So a fire in Southern California can push pathogens and organisms that were in the soil all the way up to the northern United States. This smoke plume actually ended in about Wisconsin. And we find sort of a who's who of opportunistic infections: Aspergillus, Mucorales, Cryptococcus, Cladophilophyra, et cetera. So we do think that wildfires are also playing a big role. So it was thought that it was sterile in the past. We know this is now a living component, but basically fire creates its own weather. So it entrains air through the vegetative material and the soil to throw that up into the atmosphere, lead to spread, and cause infection. So last sort of background slide here is just sort of the general pattern for patients with coccidioides, because we're only going to talk about a small group of these. So if we have 100 patients with cocci infection or valley fever, again, 60% of those are really not going to have symptoms. They might have very vague cough, fatigue, not feel well, but most of those don't come to clinical attention. They self-resolve without therapy. This 40%, though, often have more prolonged illness. The good news is, of those 40, 37 of those patients are going to fully recover with or without treatment. We don't actually know that treatment for most of these patients will speed up the resolution of disease. 3 to 4 of those, though, are going to have relapsing infection, where if they're treated, when you take patients off treatment, their infection will return over the next 6 months. And then 2 to 4% of the total patient population are going to have dissemination, where their infection is going to leave the lung and cause one of the more morbid manifestations, which is bone disease, skin disease, or meningitis. And that's really the toughest form of this disease to treat. So with these more prolonged infections and disseminated forms, and there's also chronic pulmonary infections, there's overall a fairly poor response to treatment. Their symptoms last for months. They often have fatigue for a year or more. Relapsing infection clearly occurs. And with accumulated drug exposure, again, we have to treat these patients for months or sometimes years. And in cases of coccimeningitis, they require lifelong therapy. And with that, there's a lot of intolerance and adverse events for long-term therapy. Chronic pulmonary disease also requires very long courses, some cases lifelong. It's a little bit analogous to chronic pulmonary aspergillosis. And then again, those with dissemination or meningitis are going to have some side effects with long-term therapy. So fluconazole, we've always thought of as fairly benign. But I think that most of the literature had been based, and certainly the package insert, on vulvovaginal candidiasis when we give 150 milligrams once. With coccidioidomycosis, we often have to give 800 milligrams or more for life. And with that, when we've pulled all of our patients, there's a 50% discontinuation rate of fluconazole over time. And a lot of the patients have self-discontinued that, which is a big problem because their chronic infection is going to return. Itraconazole, we really have a hard time with in some of our older patients with the edema and heart failure effects. Voriconazole is very difficult for us to give in sunny California. The photosensitizing effects of that really cause problems for patients. Drug-drug interactions are well known. Visual changes patients really dislike. Posaconazole chronically is difficult due to the development of hypertension. They'll start to accumulate meds if they get hypertension from their posaconazole. And then isavuconazole has very few adverse events associated with it, but it's difficult for us to obtain from an insurance and payer standpoint. And then this slide really shows the reasons we need new drugs. So before 2017, no one had really ever done a large-scale in vitro susceptibility study of coccidioides isolates. And so we pulled over 400 isolates, did susceptibility testing, and you can see here the MIC breakdown for those. The problem with this is this second column that's in dark blue. So fluconazole is listed in all of the guidelines as really the first-line treatment agent for coccidioides, but we found a third of the isolates had fluconazole MICs, more than 16, which we really wouldn't use for other infections. We don't do that for the other endemics. We give them itraconazole or a different azole. If this was Candida infection with that high of MICs, we probably wouldn't use fluconazole, and certainly not if we had to use chronic therapy, as there's going to be, again, cumulative side effects. And then we also found isolates with very high fluconazole MICs, more than 64. They were quite variable for the other azoles. And then the echinocannins have this tremendous spread here, and we really don't recommend those except in the deep salvage setting. There's really not proven efficacy. Coccidioides, the organism is actually 2/3 by dry weight beta-glucans, so we've had a lot of concerns that in vivo, those echinocannins may just be soaked up, and it's not clear that they're efficacious in vivo. You can see the rates of the mold-active azoles, itraposa and vori here. Resistance is fairly low, 1 to 1.2%. And then we did even find some isolates with very high amphotericin MICs. So this really sort of paints a picture that we may be treating this disease with the inappropriate first-line agents, and really some of these others, itraconazole, posaconazole, et cetera, should move up in sort of the order that we give these agents. So these cases are going to illustrate some of the problems that we experience in treating these patients. And the first one is a patient with refractory disseminated infection. This is a 29-year-old African-American female that we took care of with disseminated cocci. She had progressive disease over the last 3 months with multiple skin lesions. She also had pleural disease, and she had 4 brain lesions. She was seen initially at an outside hospital and received fluconazole at 1,000 milligrams a day for 4 months, then voriconazole for a month, and then posaconazole for 2 months, and really was refractory to all of those, did not respond, continued to develop new lesions, was admitted to an outside hospital and treated with lipid amphotericin B for 4 weeks, and continued to progress. Really no response, had ongoing infection, and then she was transferred to our center for additional evaluation. Well, at that time, we had the phase 2 Alorafem study ongoing, and we were able to enroll her into this study. And so if you don't know much about Alorafem, it has sort of a prior drug name that's F90-1318, And it's a potent inhibitor of this DHODH enzyme. That's the dihydroorotate dehydrogenase. And that's a key enzyme in pyrimidine synthesis. And you can see that pathway sort of outlined in the top right corner here. We also have the same enzyme, but there's about a 2,000-fold difference in the affinity between the fungal enzyme Biolorifim versus the human enzyme. So it's thought that there would not be a lot of toxicity crossover with Olorifim in human patients. What else is unique about Olorifim is this very high activity against molds and the endemic fungi such as Coccidioides. It works for the Lamentaspora, Cetosporium, Scapulariopsis, drug-resistant Aspergillus. So things we've really struggled with in the past, Olorifim appears to have really fantastic efficacy in. And this phase 2 trial was designed specifically for patients with refractory disease, resistant disease, or intolerant to available agents. And we'll talk just a little bit about the first 100 patients. The overall, this is all patients that included not just Cocci. 43% of those had a complete or partial response, stable response in 26%. And in the deep salvage setting, a 69% overall stability rate or better is pretty advantageous. These are patients who are going to do very poorly before the availability of this agent. You can see this is by bronchoscopy, scapulariopsis of an anastomotic site in a patient with lung transplantation, and then also a drug-resistant Aspergillus case here at the right as well that really improved on therapy. But for our patients with Cocci, we actually had called right before the phase 2 study had started and said, can we enroll some Cocci patients in this? We have a lot of patients with bad disease. And this was based really on what we saw in Nathan Wiederhold and Tom Patterson's animal model of CNS Cocci treated with Olorifim. So this slide on the left is figure A. This is the treatment for 14 days, then drug is stopped and the animals are followed for survival. And we actually saw the Olorifim treated animals did very well even after the drug was stopped, suggesting sort of a long-term benefit for therapy in this compared to fluconazole. And then in figures C and D here, you can see what that looks like in controls, fluconazole treated mice at sort of different doses, and then Olorifim done at a range finding, dose finding study in these mice infected with CNS Cocci. And the most interesting part about this study is I've already mentioned that Cocci meningitis, we have always considered that that's an indication that needs lifelong therapy. We've thought that's not curable. But what was found in this mouse model of infection is that some of these mice, there was no evidence of Cocci when the brains were cultured on autopsy or necropsy. So that was very suggestive to us that Olorifim had in vivo efficacy, and for our patients who were failing everything else, it would probably be worth a shot to give these patients drug. And so this is what our patient, sort of her treatment course looks like. So at the time of enrollment, she had multiple small brain lesions with surrounding edema, secondary to her underlying Cocci infection. So we didn't have a lot of experience with Olorifim at the time, so that was added to sort of an optimized background therapy of voriconazole at the time. You do have to dose adjust Olorifim in the presence of voriconazole. And you can see here what her skin lesions look like. She had multiple skin lesions over her body in addition to these brain lesions. But what we saw was these began to resolve. And by day 150, she kind of only had some scarring left. And then at day 256, she had complete resolution of all of her brain lesions. All of her skin lesions had completely healed. They now just have some scarring. And after about a year, 18 months of therapy, a little more, the patient self-discontinued drugs. She said, I feel great. I no longer have any infection. We were very hesitant about this and tried to talk her out of that, but she was emphatic that she was cured. And she since has gone on to have a baby without recurrence of her Cocci infection. And she's now been off medications for more than 2 years. She's someone we continue to follow. She's seen sort of outside of our system, but we touch base with her about every 6 months. She has no evidence of infection, and she might actually be an Olorifim cure of a CNS Cocci case. So more about the Cocci cases overall in this phase 2 Olorifim study. One of the problems with the current criteria for how we do clinical trials is there's a big emphasis on the mycology result. And with Cocci serologies, those are not going to go to zero for a long time, maybe even a decade. So that's why the overall response here is 0. But again, that's really an error in the way the current criteria are set rather than failure of the drug. If you look at the clinical responses, and this is just the first 11 Coxi patients in the study, there's now 41 in the total study, but 64% of these patients who'd really failed all other options had a complete or partial response. And so that's very favorable for patients who are ultimately going to die without the availability of alorafim. And then one last thing about alorafim here, just it's important to not only look at the efficacy, but the drug safety as well. Very well tolerated with dosing out to 2 years. One of our patients now has been on drug for 3 years. They were dosed for long periods of time, 84 to 722 days. And the safety does not appear to change with long-term dosing. They don't accumulate toxicity like we see with some of the azoles. It's very important to remember alorafim does have a hepatic safety signal. About 8 to 9% of the patients are going to have elevation of their LFTs. You're going to have to follow these patients closely. This is not a drug to put people on and say, see you in 3 months. Only 2% are going to require alorafim discontinuation, so very low rate of discontinuation. And then GI intolerance is seen in about 2% of these patients as well. So alorafim is a drug we're very excited about. We're ready for this drug to be on the market. Frankly, to put more of these patients who really need an active agent because they've failed everything else onto alorafim. So I think that's really a promising agent in the treatment of not just coccidioides, but certainly the drug-resistant molds as well. Okay, so to go on to our second case, and this is also a fairly common clinical setting for us. This is a patient with really intolerance to most of the other agents, 65-year-old with meningitis. And despite being on multiple past agents, he still has headache, nausea, and vomiting. There's no evidence of hydrocephalus. He has a normal opening pressure, and he's been really on all of the azoles that were available and had toxicity from these, just not able to tolerate drugs. And so he was referred to us for compassionate use fosmanogepix. And fosmanogepix, if you're not familiar with that, comes as sort of a prodrug, and then by plasma systemic phosphatases is converted to the active moiety, which was manogepix. And this is a GWT1 inhibitor, which is an enzyme that catalyzes inositol acylation. It also has pleiotropic effects throughout multiple different mechanisms. It sort of is essential for trafficking and anchoring manoproteins. So the other effects are cell wall integrity, adhesion, etc. And the mammalian ortholog does not appear inhibited by this. It has a few sort of specific holes. It doesn't work for Candida krusei or Candida kefir, but really works for most molds, most other Candida species, and most of the mucorales, and is available both IV and oral. So we had contacted the company and put our patient on fosmanogepix based on this paper that's out of the UC San Diego group with Josh Fearer that showed, this is the prior name, APX001, that showed really there's a reduction in lung colony counts, spleen, and then certainly survival with APX001, and this ABT is the vehicle that was used in this. We see that the mice at least survived longer, they gained weight, and patients with really out other options, we thought this might be an option for some of the patients. And this patient really responded well to fosmanogepix. Over 6 weeks' time, his headaches completely resolved, his nausea and vomiting went away, and he's now been on compassionate use fosmanogepix for 2 years with really resolution of all of his symptoms. Fosmanogepix is overall fairly well tolerated. The phase 2 Candida studies, there was no treatment discontinuations or study drug-related AEs. So this is a drug we don't have a whole lot of data that has accumulated for coccidioides, but we do think it's efficacious. It certainly worked for this patient and is a drug that I think is also going to play a big role in the treatment of coccidioides, but other pathogens where we need help. And then the last part of this is to focus more on where I think the field of mycology as a whole is kind of going. And this, specifically in cocci, shows that. So in coccidioides, we see infection far more commonly in men. It's about a 6-to-1 ratio compared to women for lots of reasons. Some of those are biologic, some of those are sociologic. And then obviously patients who are profoundly immunosuppressed are going to have a hard time fighting this infection. We've also seen this sort of racial predilection for bad disease. Those of oceanic genomic ancestry or Filipino have 175-fold greater risk of disseminated infection, and those of African genomic ancestry about 10-fold greater risk compared to Latino and Caucasian patients. And so we've really tried to work on the functional mechanisms of why that is and found 3 different pathways that are shared where there's polymorphism. So dectin-1, very well known in mycology for the stop codon, that's quite frequent in patients with severe coccidioidomycosis. We've also seen a number of patients with this PCLG2 mutation. That's also seen in patients with inflammatory bowel disease. And then some of the patients have a polymorphism in DUOX1, and that's one of the pathways whereby we make hydrogen peroxide. So these 3 different genomic polymorphisms seem to play a tremendous role in host susceptibility to infection. So one of the questions is, can we fix these things? Can we try to augment patients' immune response so that they can fight off the infection and maybe even cure them so that they don't need lifelong antifungal therapy? And this case really shows that. It's really the future and how we're trying to move towards true precision medicine in infectious disease. And this is a 4-year-old boy who had fever and 3 weeks of enlarging nodules over his forehead. And these masses were fairly large, 3 to 5 centimeters. And you can see what that looks like on the PET scan there. These masses were overlying his scalp. Also had tenderness on the right wrist and ankle. You can see lesions here on his right wrist, also within his knee. Some of these were subclinical. And then a biopsy of the scalp lesion shows this very classic appearance of a coccidioides spherule. And so this patient was taken care of by colleagues at UCLA. And I know some people love flow cytometry. I'm more of a novice, but you can see what that looks like here is with interleukin-12 stimulation of his T cells. He had very little response, but did show some response, didn't have complete neglect of this IL-12 stimulation here. And then if you move to the middle of figure E, this looks at his interleukin-4 and interferon gamma responses. You can see he's really sort of Th2 shifted there with more IL-4 production, very little interferon gamma. And then if you give him coccidioides antigen in repeat flow, you can see mostly just makes IL-4 to that, very little interferon gamma. So genome sequencing of this patient really didn't find obvious deleterious polymorphisms. They did RNA sequencing as well and had found this interleukin-12 receptor variant was expressed differently. And it's unclear why that occurred. It could be epigenetic change. It may have been aberrantly spliced. But it was thought they could potentially overcome this with exogenous interferon gamma. And this figure C at the bottom, again, based on this precision medicine sort of assessment of an individual patient, really gave the impetus for why they did this. So since he's Th2 shifted, they wanted to give him dupilumab. And since he's not making much interferon gamma, they wanted to supplement him with that as well. So schematically, he was on fluconazole, then he received amphotericin B, received sertraline. Sertraline has some activity against most fungi, certainly Cryptococcus. There's a nice paper by Dave Boulware's group showing that in Cryptococcus clinical trial. Didn't work that well, but same kind of thought process was used for salvage setting with coccidioides here. Then he was put on interferon gamma and dupilumab over time as well. And you can see what that looks like. So over time from week 0 to week 27, really had most near resolution of disease on his MRI. So again, these are scalp lesions, so look outside of the brain cortex here. And you can see there's initial sort of enlargement as his immune system begins to recognize those, with resolution by week 27 and then near resolution in the spine by week 31. And when they re-looked at his flow, you saw really his CD4 cells there in the bottom left. Their interleukin-4 began to reduce as he began to lose his Th2 response. Interferon gamma began to increase with exogenous supplementation. And you see sort of a correction of his Th1, Th2 ratio over time, and then compared to healthy controls. So we do think that this is setting the stage and just additional example of how we can use personalized medicine going forward in the field of mycology. To finish up, we have lots of new drugs coming out. There's some others I'm not going to talk about. This oral lipid nanocrystal amphotericin B. We don't have data for that in coccidioides. It's required 6 times a day, so it's difficult to take long term. Kinocannins and triterpenoids, we don't have data. They might be able to be used in combination, but more data needed in that area as well. But wanted to thank you again for your attention, for the invitation to speak today.